It's 10 after. We're going to get the meeting started. I know we have one member in transit. She has let me know. Another member is watching online. We may have more join us online. Hello to all of you who are watching the March meeting of the Medicaid Client Voice Council online. My name is Jason Peterson, Chief Deputy. Actually, that's not true anymore. I've had a change in title. I'm now Director of Constituent Services at the Department of Human Services, but my duties here will remain until otherwise told, so I will continue to be the point person for the Medicaid Client Voice Council. We're going to talk about some changes coming up this summer for this council, the addition of the Medicaid Advisory Committee, and how that will impact us as a council. So we'll talk about that. We've also got some presentations this morning on the legislative progress on improving maternal health in the state, as well as the Pathway to Prosperity, which affects Medicaid beneficiaries, some of them. So we'll talk about that. Elizabeth Pittman's going to be the star of the show for the first hour until we get to lunch. And then in the second hour, or the second half of the meeting, we're going to talk about that live demo we did with Access Arkansas. For those of you who participated in that, we could talk about what we learned, what changes might be suggested or made, and if some of you have written notices you've received, communications from DHS, Mary's here. We can talk about those, look at those, see what changes, or she can explain to you the process that we do at DHS to try to make those as clear and as simple as possible. But maybe there's some improvements that you guys have, some suggestions you want to make, so we can talk about that as well. Let me remind you, when we get to kind of exchange of comments and ideas, for the folks watching online, you need a microphone in front of you if they're going to hear you. It doesn't help that much in this room. It does a little bit. But it helps tremendously for those watching online. And I go back and watch the meeting later. We record it and we post it on the website. And so I know that if someone doesn't have a microphone in front of them, there is no audio. You cannot hear them. So we've got 2 microphones here. I'll distribute them as we go around doing Q&As and comments. And actually, I'm going to start right now because Brandy Vaughter is your chairperson. And I'm going to invite her to welcome you. And if she has any opening comments, she can share them at this time.
Thank you. Good morning and welcome to everyone. Just wanted to say a special thank you to Mary and her team for that Access Arkansas live demo. That was really a wealth of information and was much needed, especially for me at that time, and really answered a lot of questions that I had. So I appreciate that, and I appreciate y'all's willingness to listen to our questions and to address those. So thank you very much.
All right, Jennifer, I'm sorry. You, as vice chairperson, you're good. You don't have an opening comment or statement. Okay, all right. You're just in learning mode. Okay. All right, well, let's get started. If those who are running late filter in, they can catch up. But we wanted to give you a legislative update on what's been going on in the area of maternal health. This has been a hot topic in the state, improving maternal health statewide, and how we can best do that, improve our rankings and improve just life for the women and their babies. So Governor Sanders has signed now into law a package of initiatives aimed at improving maternal health outcomes in Arkansas. And so our Division of Medical Services Director, Elizabeth Pittman, is joining us here to update you, the council, on what that means for Arkansas and our expectant or new mothers.
Good morning. Sorry, I don't have any slides on this one. I'm kind of winging it, but we'll have fun and we can have a conversation. All right, so as Mr. Peterson said, the governor recently signed into legislation 2 acts, Act 124 and Act 140. They're omnibus acts, so they are identical. One came out of the Senate and one came out of the House, and they are called Healthy Moms, Healthy Babies. You can Google it and see her press conference. You can actually read the acts if you would like. And they do a lot to, it's basically the culmination of the work that the task force that we told you about last year has been doing over the past year. That task force started convening in early 2024. It was the Health Department, the Department of Human Services, the Surgeon General, members of AFMC, of the state legislature, of physicians groups like the Arkansas Medical Society and the pediatricians. It included all sorts of stakeholders that came together and met to discuss how to address the maternal health crisis in Arkansas. Arkansas has some of the worst maternal health statistics in the nation. I don't know if you're aware of that or not, but we are at the bottom of many of those things, including maternal mortality, which is women who die during childbirth or immediately after, and maternal morbidity, which is those that get sick and have complications. We're at the bottom of low infant birth weights, so babies born prematurely or very, very small. And so how do we improve that and make moms and families and children healthier so that we have a more healthy, more vital Arkansas? That was the discussion that we were having. And that work group came up with a lot of ideas, and some of common themes. We need better data infrastructure. We need to communicate with each other better on what we're doing and how we're doing it. We need more providers. We don't have enough, particularly in rural areas. Women who have high-risk pregnancies have to travel very long distances to see specialists. How do we address that? We don't have a lot of alternative providers like certified nurse midwives or doulas in the state of Arkansas to help provide care to lower risk pregnancies that maybe don't need a high risk specialist. We are woefully behind in how we pay for births here in Arkansas, particularly as Medicaid. We're still using a very outdated global payment system where we pay you one fee for every visit you see of that mother from the time you start seeing them until the postpartum visit. And it was an over 20-year-old payment. It was very small. And because of that payment system, we couldn't tell when a woman started receiving care at the front end or how many visits she had after the delivery. So we couldn't really tell what was going on, and we ended up having to match to vital records with the health department to be able to find out when women were even going in for their first prenatal visit. And what we found wasn't great news either. We had a lot of pockets of the state where the percentage of women who didn't go in until even their third trimester was pretty high, and that's not good for healthy babies. So we found a lot of things we needed to address. And we wanted to do a lot of different things. And so they put together a work plan that you can read, a report to the governor, worked with state legislators. We applied for a grant called Transforming Maternal Health. We received it in January of this year. It's a $17 million grant, and it's given out over 10 years. And through that grant, we will address a lot of the things that we just talked about, adding in new provider types, including community health workers and doulas, adding in a value-based payment system to pay for better outcomes, investing in programs that focus on outcomes, things like birthing-friendly hospitals, where the hospital receives a designation that they are a place that is safe for deliveries, and also that they do something called AIM. And I'm not going to remember what that stands for, but AIM is a series of educational materials that hospitals use to address high-risk pregnancy situations like sepsis or infection, hypertension after birth, which is a common complication, things of that nature. The hospital that maybe doesn't have an OB unit is trained in how to address that so that if a woman comes into an ER, she can be adequately treated. For example, a woman who's postpartum may have a slightly elevated blood pressure that normally wouldn't cause a great concern in you or me. In her, it's pretty significant. So you want the hospital to recognize that and not just send her home. And that's what the AIM bundles help to do. So that team helps us invest in those types of things. Then, after all of that, we worked with several of our state legislators to put together this package of Healthy Moms, Healthy Babies. We're really excited. The governor announced it, and we're really excited about everything it's going to do. In this package, we are putting $13 million of state general revenue into maternal health. It was earmarked for maternal health by the governor. It is new money to the Medicaid program, so it's not taking away from anything else. And it's going to be matched by the federal government to equal 45 million new Medicaid dollars going to maternal health in Arkansas, which is huge news. And with that money, we are going to unbundle those delivery payments. So now providers who are seeing women can get paid for every visit, postpartum, prenatal, and the delivery. And we're going to do a 70% rate increase, which, trust me, in the entire time I've worked for Medicaid, I've never seen a 70% rate increase. So that is massively huge and very exciting. And I will tell you, the delivery rates before were woefully outdated. I think we were paying less than $2,000 for a natural delivery, which is pretty terrible if you talk to a doctor. So we really need this, and it's really exciting. So that's the biggest piece of it. But the other things we're doing, and Mary can tell you more about presumptive eligibility, but we're doing presumptive eligibility for pregnant women. And that is a special type of eligibility that when a woman goes to her first prenatal visit and the doctor thinks, or the FQHC or wherever she is, thinks that she might qualify for Medicaid, he can refer her over to Mary's team. They'll do some preliminary checks, and if it does look like she qualifies, she becomes what's called presumptively eligible for 60 days. And during that time, she can go ahead and go to the doctor. They can bill us for those services, for the traditional prenatal care, prenatal vitamins, the labs that are needed, the ultrasounds that are needed. All of that can be billed to Medicaid while that full application is pending. So she can go ahead and access the care. That was one of the biggest barriers we learned about to prenatal care, that providers weren't willing to risk that that client was going to complete the application, become Medicaid eligible, and that was going to retro back to when they were providing those services. Typically would have, but that was a risk that they would have had to take, and a lot of them were not willing to take that. So there was a hard time for those stopgap providers like federally qualified health centers or health departments finding OBs that wanted to take women who did not have insurance yet. And so this helps address that. They now have a billing source while that application is pending. And we can get that woman into that care much faster. And that care then stays consistent in the early part of that pregnancy. The only real exclusion to that is there is no inpatient care covered. If you do need to go to the inpatient hospital, you work with Mary's team to get on that type of Medicaid coverage. So it's not that that would not be covered through Medicaid. It's just there's a different mechanism for that. So we don't put that in that presumptive eligibility. So that's the other piece. That bill also requires us to add doulas and community health workers as provider types to Medicaid. Both of these provider types are alternative provider types. They do not deliver babies, and doula was a new term for a lot of us. It's something I've heard on and off, but it's not something I was super familiar with before getting into this. But they are assistants that help pregnant women navigate prenatal care, the hospital system, help with lactation, making sure the home is ready, what to expect during birth, creating a birthing plan. These are things that help women who are not as familiar with the health system, or maybe who have a hard time having their voice heard in the health system, to have that voice heard and make sure that that birth plan addresses their needs, and particularly if they're high risk, that those needs can be addressed adequately by their professionals. So a lot of other states have started paying for doulas. They're really helpful in creating equal access to health care across the state in all areas. And so that's something that we really wanted to look into, and something this bill mandates. So we're pretty excited about that. Community health workers are similar in nature. They're more broad-based trained. They're not specialized in delivery, although they can be. But they do similar activities. They help advocate for the patient. They help them navigate the healthcare system and learn basic healthcare information. And let's see, I'm sure I'm forgetting something. Oh, yes. We're also going to be covering continuous glucose monitors and blood pressure cuffs for pregnant women who have need for those. We already cover the actual equipment. Actually, if you're pregnant today and have gestational diabetes, you can get a CGM through Medicaid, but we don't have any monitoring on the back end. You are responsible for monitoring and calling your doctor if you need any follow-up. What this bill does is put monitoring in place. So we will do remote monitoring. Got to figure out how, but we're working on it. Remote monitoring for the CGMs, the blood pressure cuffs, and we're also doing some remote fetal ultrasounds, which that's all I can tell you right now, but it sounds really cool and I'm excited about it. So we're working on all of that and doing more remote care through Medicaid so that women don't have to go into where specialists are to have that care. So any questions about that package? If not, the timeline I'll just go over that real fast. The timeline for implementation is very aggressive. We're working on presumptive eligibility and the unbundling of the payments for July 1st of this year. And then the remainder is supposed to come online in October 1st of this year, assuming we can get all of the pieces worked out. So, all right.
First, thank you for doing this, and thank you for being so excited about it. But I have a question that is just kind of random. How many doulas do we have in the state? Do we know?
We are still trying to get good numbers because there hasn't been a statewide alliance until very recently. There is a statewide alliance now. I'm working with some UAMS team members who know them to make those connections so we can start working with them. There's also a training at UAMS right now, so I can't tell you the exact number today. That training at UAMS is about 8 months. Right now, they have about 30 people that have completed it, and they're hoping to have 80 by the end of the year, I believe.
And are those, do you know, are those spread out throughout the state, or is it?
I don't know that. That's what we need to get with the Doula Alliance to find out. But there is a statewide Doula Alliance, and hopefully we'll get that information soon.
Thank you, Elizabeth. I had a question about, I think I read and saw in the press conference that it wasn't decided to do the expanded coverage to 12 months, but it seems like there was a really clear message from the governor that there would be a way to transition these moms, because as we know, I'm speaking from being a behavioral health clinician, that's the time when a lot of the problems come about is 12 months, the postpartum and any issues, but it seemed like there was a real clear focus on you're going to transition them to other Medicaid programs so they don't get lost.
Yes, Mary can probably speak better to this. She is putting some work in place to make contacts and outreaches to moms to make sure their coverage remains, and I'll let her speak to it.
So good morning, everyone. We are actually getting ready next month to start a specific outreach campaign to moms that are postpartum, and it appears that their coverage is going to end in our system. So we're going to be doing some specific outreach, phone calls, texts, emails. We will also, if they are losing coverage because their income is too high to continue on in Medicaid in a regular category, and we can reach them, we're actually going to be working with a partner, working on a contract amendment that we expect to go to review next month, who will also then help them contact through AID how to transition into the marketplace. So it'll include both of those things. And I did want to share just a little bit more information with them about presumptive eligibility for pregnant women. And as Elizabeth said, it's a very rapid timeline, but I just wanted to explain to you a little bit more about how that's going to work. And there are going to be some benefits, byproduct benefits to everyone in this, whether you are pregnant or not. But we are going to shorten our application. And it will go live when presumptive eligibility goes live. So I don't have a preview of it to share today, but maybe by the next meeting we can share. And because of this timeline, unfortunately, we aren't going to have time to go, what would you change? What do you like? What do you not like? But we can still take that down, but you'll be able to see, because to get it done and get it translated and get it ready to go, we've just had to move very quickly. But we're working to shorten that application because we don't just want to approve people for presumptive eligibility. We want to if they're eligible, but at the same time, we'll be getting the regular application so they don't have to do a two-step process, the presumptive process and then the regular process. And what we will do is if they appear to be income eligible for presumptive eligibility, we will go ahead and approve them if we aren't able to immediately approve them in a regular Medicaid category or for the full pregnancy coverage. So if we have to pend the application, I think Elizabeth did mention that, then we would go ahead and approve the presumptive while it's pending, while they're gathering whatever information we needed in order to determine eligibility for the full coverage benefit. So we're excited about that, and I think people will be excited about the shorter application, even if you have suggestions for how we can improve it from there.
Any other questions for Elizabeth on this topic? Let me ask one.
Okay.
Reimbursement rates are great. It'll create more opportunities. But what about, there was talk about how do we convince pregnant mothers about the importance of going to the doctor, about the, is there any outreach effort going to be made, like through advertising or through, I don't know. How do you convince pregnant mothers that they need prenatal care, they need postpartum care, to help with the outcomes?
So I take it you'll volunteer for that work group?
I mean, sure.
Okay. No, that's a great question, and something we definitely do want to consider as we're working through all of this is how do we do outreach. We work closely with Gavin's team on doing other campaigns. I don't know that we've gotten to that part yet to give you specific details, but I know in the past we've done like vaccination campaigns, and We just recently did an RSV campaign to let you know what coverage is available and why you should look for it and do it. We'll do something similar here. Please, Gavin, help me.
As part of the big initiative that Governor Sanders kicked off, she also set aside funds for an advertising and outreach campaign specifically for maternal health. That's going to live with the health department, and I think they have just gotten the vendor who's going to handle that. But I don't know the exact amount, but it's a multi-million-dollar outreach and education campaign. They'll be the lead on it. We certainly will play a role. It will focus on maternal health in general, but certainly there will be information about Medicaid eligibility and our side of the house too. But there's a big investment there, and that's going to be coming online here in the coming months.
And as you can tell, a lot of us worked on it and have a lot of information. So I'm definitely not the only one who has been involved and can give you information on this. It's a huge effort from the state.
All right, Elizabeth, stay where you are. Elizabeth does have another presentation before we break for lunch on Pathway to Prosperity. For those of you who are unfamiliar with it, she'll give you a little background, but she'll also tell you on how that's progressing. That's another legislative effort that's ongoing. Is that not right?
It is becoming one.
Becoming one.
Yes.
Okay. Okay. All right. Elizabeth?
All right. Okay. Pathway to Prosperity is a new amendment to our Home 1115 waiver. It was announced by the governor on January 28th of this year, and it is a new initiative to help Medicaid recipients to move into the workforce and to improve their economic independence. It is to allow for a work requirement for Arkansas home beneficiaries, which is something that the federal government is currently considering making mandatory on Medicaid as a cost savings measure. Poverty is closely connected to poor health outcomes. You can read a lot about this, and in fact, we have to move forward and develop this waiver. We wanted to address that, and in fact, Medicaid was designed to address that. And so the purpose of Pathway to Prosperity is to provide focused care coordination and personal development for members to help support them as they achieve economic independence, help them to develop their own goals and how they want to move that forward. So you might have heard of the benefits cliff. It's something that's commonly used in politics to talk about social programs like Medicaid. And what that means is when you are on a social benefit and you go out and you start earning a little bit more income, just a little bit more, all of a sudden you're no longer eligible for those benefits, but the amount of income that you've received doesn't really compensate for the benefits that you've lost, right? So there's a cliff, there's a big gap. That's what the benefit cliff is. Like I said, it's something that people in politics and policy have talked about for a long time and tried to figure out how to address. Pathways to Prosperity is what we believe is a way to help address this. And sorry, I don't know why my throat's so dry this morning, but the purpose of Pathway to Prosperity is to bridge that cliff and to help people to understand how to navigate insurance, what that is before they move out of the Medicaid benefit and into the more traditional insurance space. So what is the history of the work requirement? I'm sure we all know Arkansas implemented a work requirement in 2018. Got a lot of press. Wasn't successful. It only lasted for about 3 months. So what did we learn from that? It was challenged in court. It was halted by a federal judge, finding that we had failed to consider the effects of the project on coverage alone. So that judge, thank you so much. I'm going to take a sip of the water. And now I'm going to sound a little bit like a lawyer. So sorry about that. They told me once when I went to law school that I was going to sound like a lawyer for the rest of my life. They were not wrong, unfortunately. They should tell you not to go to law school for that reason. So what that means is we failed to look at what the loss of coverage would mean, and that was the purpose of the expansion, and by not doing that, the 1115 wasn't appropriate. It also showed that many people really didn't understand what the requirements were, what they were supposed to do, how they were supposed to report, what would demonstrate compliance. So what did we learn? We learned that we had to provide very clear communication on what was expected of people and when. We needed a simple design, not something that was complicated or hard to follow. And we needed personal interaction with people, not over-reliance on technology There needed to be a human touch, because this program is for humans. So what have we done to make it better, we think? We have started using data matching. So you're not just expected to know whether or not you're in compliance or need to go to try to fulfill this requirement. We are going to data match with other state agencies to help determine if you are what we call on track or off track. We're going to, if you are off track, which means you're not working, you're not engaged in a community activity, you're not receiving treatment for a chronic health condition or substance use disorder, you're not caring for a small child, anything like that would put you on track. If you're not, we can't data match that, then we're going to assign you to a person who will provide you with success coaching. The success coaching is the first conversation they'll have with you. If our data matching missed something and you are in fact on track, they will then report that to us, you're done. If not, they will help create a personal development plan that addresses your own barriers to achieving economic independence. Is it that you have a particular skill that you want to develop and turn into a career that can get you in an education track? Is it that you have a substance use problem and so you're not really in a place where you can go to work every day? They'll help get you into treatment. Whatever it is that you need. Do you need childcare so you can go back to work? They'll help with that too. So they'll do all of that. They'll document your activities and progress in that plan, and as long as that's being done, you're on track. And the last thing we're doing here is if you are not on track after 3 months of working with a success coach or failing to work with a success coach, instead of disenrolling you from Medicaid, to where if you wanted to come back, you would have to start the application on day one and go through that whole process, we're suspending the coverage. So what that means is if you decide 2 days later you want to participate in the program and get back on the rolls of Medicaid, you call your county office, they say, okay. You call your success coach, they say, okay. They put you back in the system and your Medicaid can be turned on much faster. So you don't have to go back through that full application process. Unless your renewal comes up, we can't change your renewal cycle, then you, of course, would have to if you don't renew. What are the program goals? To increase income of our beneficiaries, higher earnings would be supported by the success coaching. Use healthcare coverage. We want people to use the coverage they have. We want a greater percentage of enrollees accessing the services, particularly those preventative services available through the Affordable Care Act, which are the plans that we buy through QHPs. They include well visits and all of the nationally recommended screenings for cancer or other health conditions. We want people getting those. We want to increase access to private coverage or maintain coverage in the appropriate model. If that's Medicaid, we want to keep you there. But we want to make sure it's where you need to be. And we want to address your health-related social needs. So the development plan is not just focused on career. If you need help finding housing, if you need help finding food, it will help you with that as well. Because I don't know about you, but if I don't have a warm, safe place to sleep or access to food, going to work every day is not going to be my top priority. So we have to address those things first. So I think I went through all of this already. The success coach will make a contact to determine if you really do need a personal development plan or if there was something we missed in our data matching. We will focus on care coordination to really help you. And then again, it's an individualized plan. This is not a one-size-fits-all model, go get 20 hours of work a week and report it back to us. This is how can we help you to find sustainable community engagement. Volunteering counts, staying at home and caring for your loved one counts, going to work counts. Success coaching includes reporting in a case management system, identifying the health-related social needs and helping you to access community services. So it does mean knowing what community services are available. So we want success coaching to include people that understand those community resources. Development of that PDP, or personal development plan. You know, DHS has to have an acronym, so it's going to be the PDP. It'll be tracked at 3 months intervals, documenting your progress monthly, and then doing follow-up activities. So the waiver was out for public comment through January 28th through March 3rd. We had 4 public hearings, 2 in person, 1 here in Little Rock and 1 in Fort Smith. We received 55 public comments. some favorable, some unfavorable. Comments came in from medical associations, public policy advocates, and individuals. Well, these were the public comments and our responses. And I'll just go through these. I won't read all of it, so you have the slides. If you have any questions, please ask. The first one was that it was a barrier to coverage, particularly for those with chronic conditions. And as I had said earlier, and we tried to make clear through our responses, which will be published soon, if you are receiving treatment for a chronic condition, you are exempt from, you are considered on track. You're engaged in your health care, you're undergoing chronic treatment. There's no expectation that you would do anything additional. Given the experiences of previous work requirements, there are some challenges to implementation. We are trying to take a fresh approach here to not do a monthly self-reporting, which was done before, but to do more of a hands-on personalized approach with data matching. We need more specification in our waiver notice and application that was put out. Typically, details regarding things that were asked about are not put in the application itself. They're negotiated with CMS and put into what is called the standard terms and conditions, which is a document that is publicly available once it's created. We then have to develop with CMS an implementation plan and a protocol that they approve, and so all of that will contain all of those details. This proposal simply asks what we want CMS to waive of the standard Medicaid requirements. The next one was that it still conflicted with the goals of Medicaid. But again, we believe that poverty is the greatest predictor of poor health and that Medicaid is an anti-poverty program. So that we believe that using this Section 1115 is the best tool available. It will fail to improve employment and drive economic instability for families. Again, we believe it's significantly different from the previous efforts. It's taking an individualized approach. It's not a one-size-fits-all. We're offering opportunities to address all goals for people being healthy, employed, advancing in their community, learning, and serving. It's going to be expensive to implement. We consider implementation costs justifiable investments to assist individuals in Arkansas with greater achievement. It will put hospitals and the healthcare system at risk. As the 2023 disenrollments from COVID demonstrate, that is not accurate. The majority of individuals who leave do obtain coverage in another venue. All right, so what comes next? From the last day of our public hearing, which was March 3rd, to the day that we can submit, there has to be 20 days. So we will not submit before March 24th, is that right? Yeah. Oh, it's right there on the slide, just read. All right. If you would like to find out more information, the link in the slide deck is on here. You can also just go to our website and go to public comments, where it has DHS rules for public comment, and find it there. You will find all the documents, and once our responses are published, you'll find our comments and responses as well. And that's it. Happy to take any questions.
Got questions, all right?
My question is, did you guys address the high cost of housing that is causing people to not qualify because of their jobs, and then they're paying half their paycheck out for housing and utilities and those kind of burdens? I think that's something that's came up in our area, in Gentry area, really bad.
Yeah.
Fayetteville, those kind of places.
So we're hoping that with the plans we can address the costs of everything, how to find affordable housing, how to create a plan that allows you to obtain a career that can pay for all of that. Unfortunately, Medicaid has pretty strict rules around what we can pay for. And around housing and food, there's very, very limited rules. Under the old administration, there was some allowance. Under the new, I don't know. So I don't know that we would be able to specifically contribute to that, but we are hoping with the PDPs we can address that issue.
Other questions?
So do you know yet how many people you think might be off track? Just an estimate?
We have an estimate in the waiver, and I don't want to quote it for you right now because I will get the number wrong. It's
Okay.
pretty small,
Okay.
but you can find it in that document.
That's what I wondered, if you're taking more of a personal approach.
We don't expect there to be a huge number.
Good, okay.
I just have a couple of questions. Is Arkansas Rehab Services involved at all with the work component? And my next question is a PASS, are they involved with the social determinants of health component because they're required to have a social determinants of health program to help resolve those issues?
So to the first question, I don't know that we've engaged workforce services and rehab services yet. That would be a Christie question. Gavin may know more, Secretary Putnam. Yes, but the intention is to engage them for that piece. For the second question, we have not engaged the PASSes. That population is specifically excluded. So there is now a mechanism if you're enrolled through our home and you do meet the criteria of PASS, you can be put in a PASS. But if that happens, you would be moved out of needing to meet this requirement. So,
And my last is just a comment. I wanted to give a shout out to Mary and her team. We talked about the community section on Access Arkansas, which seems like it would be able to help resolve some of these issues if you're teaching your members to be able to utilize that. If I understood that section correctly, I was technology challenged and couldn't see the screen, but I heard it. So
I'm always technology challenged.
Other questions?
So similar to what Jennifer was talking about, I'm an OT, and so I've gone to a lot of rural areas. I've seen a lot of things, a lot of people that are on Medicaid. And I love the program. That Goal 4 just warms my heart in so many ways. But one of my bigger concerns, a lot of people want to get employed. They even have the skills to get employed. The transportation is the big issue. And right now, it's not like they can call a Medicaid van to come get them and take them into town, you know. So, I mean, what are the thoughts on that?
And actually with Life 360, we looked at doing some non-medical transportation. That's what it's called. CMS has to give everything a special name. It's called non-medical transportation.
Right.
That was never approved. So unfortunately, with Medicaid, again, we have very limited ways that we can use the dollars that we have.
Right.
So our mechanism here is through the development of that personal development plan. If transportation is the barrier, and I know in rural areas it often can be, because there's not a bus system or a big Lyft Uber community, that would be part of that PDP. How do we address getting you to your job?
Right. And giving them 3 months to address it is...
Well, if they're working towards it, then that 3 months, they check those boxes. So if they develop that plan, and it's not necessarily in the way it's written today, and again, the federal government is discussing other things, so I have no control over that.
Yeah.
But in the way it's written today, if you're moving towards that goal, then you're in compliance.
Excellent. Excellent. Thank you.
Jacqueline, did you have a comment or question?
I'm glad you said something about that because
About transportation.
because I face barriers with that too, along with people that I know. I have 2 college degrees and I'm certified in rehabilitation counseling myself, and when there's no extra transportation available or staff to even pull from because of staffing shortages, where do we go?
So that's what that personal development plan will have to address is there's no transportation. What sources and resources can we find? Because like I said, unfortunately, Medicaid is not able to offer that through the rules that were given by the federal government.
Thank you.
Any other questions for Elizabeth? So these coaches, if it gets approved, we'll be hiring coaches as an agency? No?
Not necessarily,
No.
no. We are looking at existing resources, including workforce services and rehab, including the QHPs themselves, to see if there's a better avenue.
All right. No other questions? All right. Thank you, Elizabeth. The Elizabeth Pittman Show has concluded for this, yes. And she did it so efficiently that we're going to eat a little early today. She is finished. By the way, if you're watching online, you've got my cell phone. If you have questions as a member and would like to contribute to the conversation, just text me and I will add those questions as part of our discussion. But right now we will break for 30 minutes for lunch, and when we come back, we will learn a little bit more. We'll talk about our Access Arkansas live demo that we did. Welcome back to the second half of the Medicaid Client Voice Council meeting. Show of hands, who had the peanut butter cookie? I have one. And who had the chocolate chip? They were both really good. I had one of each, maybe two of one and one of the other. People were giving me their cookies. By the way, in case you're curious, that was from Bonetta's Desserts here in Little Rock. Bonetta is the one who makes those. You know, at the end of the year, we have our end of the year Medicaid Client Voice Council meeting, and they have those cupcakes or cookies that have MCVC on them. She makes those. A few of you will know that. Some of you who are new don't know that. But so Bonetta Finley is the owner, in case you were interested or wondering. So we're going to juggle the lineup for the second half a little bit. I mentioned last time we met that this is a really busy time of year for DHS leadership. Secretary Putnam sends her regards. She's at the Capitol. Janet Mann, her deputy's at the Capitol. A lot of our staff are at the Capitol, sitting in on meetings, watching what our lawmakers are doing and how it might pertain to our agency. We talked about that last week. So we're going to lose some brain trust again for meetings this afternoon. So before we do, we wanted to move straight to the Q&A portion of the meeting while we have that collected intellect, DHS intellect in the room. So if you have general questions, general Medicaid related questions, not so much about Access Arkansas demo we did, but just on any topic, we'll take some time right now to ask those questions and hopefully get them answered. So if you have a question, either if you're at home watching, you can text me, but if you're here in the room, just raise your hand, I'll bring you a mic, and you can fire away. Anybody have any general Medicaid related questions on things that are going on? Yeah, we're going to talk about that in the Access Arkansas part. Or we could do that now if you want to talk about written notices now, or would you want to save that for the... Okay, why don't we, might as well, because it's not exactly the Access Arkansas portal related. So Brandy has a copy of some written notices. So let's see how this would be best done. What do you think? This is language issues or timing issues, all of the above. All right, let me bring this over to you.
All the above. So I've been compiling for about the past year notices of from different types of Medicaid services and different types of notices. For instance, a request for information, a notice of action, and then also I even got a benefit renewal notification as well, which was by far the largest the largest one at like 12 pages or whatever it was. So I then also met with several of my clients and their families who were receiving these documents in the mail, because quite honestly, this is what I get the most phone calls about after I've helped a client through the Medicaid process. So when they get something in the mail, they are just deer in the headlights. They cannot understand it. And so just in looking at it, some of the things that I note and that we've all just kind of been talking about here is just some of the ways that it's written, some of the bolded print maybe I think draws the eye. Like for instance, on a notice of action, it's got here denials or closure in benefits. So of course your eye is drawn to that because it's a big bold statement. But then underneath that, it gives a statement if a person has been denied. So then you're going, well, have I been denied or have I not been denied? And then when you go down into the little box underneath it, that is what I think my clients have the most problem with, is who is not eligible. Sometimes they don't, sometimes they see the not, sometimes they don't. It gives the person's name, their ID, their client ID, and then it gives the effective period. And for this particular notice of action, this person was closed because they had passed away. But that just, if there's any way to, I don't know how to simplify that information for them, but it's just very confusing in that block form, and they can't ever, like change or continued benefits. What does that mean? They don't understand. There's just a lot of verbiage that they don't understand. And then there's a lot of information. It's just too much information. I think it just needs to be in its simplest form. And then all of the, things that come in addition to that, who can help if you have a question. And a lot of times up at the top, lately I have noticed at least that whatever agent is assigned to that case has been kind enough to put a direct phone number. That is worth its weight in gold, that you don't have to go through the general customer service. So I've just kind of got, the different forms and a lot of suggestions that go along with those.
And we appreciate all of those suggestions. And I was gonna ask you, are those copies, have you marked them up, like,
Well,
because I would actually appreciate that. If you
Yes,
would
I was actually
circle
going
and
to
say,
go
"This is
home and-
confusing, and could you do this differently?"
I've got a
and
couple of
send that
clients
to
that I'm
me.
going to meet with this week and ask them to help me help ask that, because they're the ones that are, I understand them, but it's the clients themselves that are not understanding them. So I'm going to meet with them later this week and actually ask them to help me mark these up. And I'll then scan those into you with those suggestions of what actual senior adults that are reading these are, because that's basically my genre, that they just do not understand.
So we also are working on notices, and we worked for months and months on notices and language and format before we launched the new system. But there are a lot of things that we have noticed now that we are using the system. And one thing I can say is when you're looking at mock-ups and when you're testing things, there's no way to test every possible scenario and what will end up on the notice when you're testing. But we have a lot of live experience now, and we agree with a lot of what you said, particularly too much information. Some of what we're providing is too much information. Some of the language we're using is not clear. Too much information being that you are eligible for this, whatever the program is, but you're denied for this, and this. Don't necessarily need to know that. It's good that we are checking all possibilities when someone applies for assistance. That's what we should be doing, but really confusing when we tell you in a notice, because then you're seeing approved and denied in the same notice, and even that causes questions. So we've noticed a lot of that, and we have a work group going on internally, and they've been meeting for months over the verbiage, the language, the placement, and we're gonna even do more work after that to look at even changing the look of the notices. This is something we're gonna have to implement in phases, and I have decided that working on notices, it's gonna be a continuous process, because it's as soon as you do something, then we're gonna see other things that we can then go back and improve on. So I think that is just gonna be part of the evolution. We're gonna learn, we're gonna make changes and make improvements, and then we're gonna learn from that and go back and make changes and make improvements. So it is on our radar. Our team has been meeting, but what you're talking about doing and like marking up a specific example and sending that, if you guys could email that to me, that would be wonderful, so that we can take that feedback as we're designing these new notices. We also would like, and I said phases, we would also like to start using some functionality that you see now all the time. Y'all know the QR codes, how you can put your camera on a QR code and it'll give you a link to follow. We want to start utilizing some of that to help you upload documents, like right there from that link. I mean, we love our Access Arkansas, and we're happy for clients to use it. We want people to create accounts and use Access Arkansas. But this would also provide you a fast way to upload a document, even if you didn't have a full-blown account on Access Arkansas. So we're looking at some improvements like that as well. But I agree, and it's helpful, the feedback you gave about the bold statements and then underneath starting with an if. So, and change or continued, what does that mean? And maybe just some simple explanation rather than trying to have all the categories, that is some good feedback. So I appreciate that. I don't have a date that I can give you. Okay, we're gonna, implement phase 1 on this date, because this group has still been meeting weekly on looking at every piece of language that might ever go on a notice and saying, can we word this better? So, but we're working on it.
So Brandy, Brandy has a lot of examples here. If some of the rest of you have examples of notices you've received or that someone else has received that you would like to add to her collection, why don't she be the collector of the council's notices? And once she has a packet ready for delivery, she can get them to me or Mary directly, however you prefer to do it. And so Mary can just get the packet of suggestions in one fell swoop. So let's say 2 weeks. Spend the next 2 weeks collecting, gathering these notices, marking them up. This could be better. This doesn't need to be here, whatever you think. Get them to Brandy, and then we'll get them to Mary.
And you feel free to de-identify those. You know, we don't need to know who the specific person is to get the feedback about the content. So if you're uncomfortable with that, feel free to de-identify it and just know that we won't be sharing it outside with anyone else. It will be just for the purposes of seeing what we can learn and how we can improve the notices.
Hi, Mary. This is kind of on those lines. When service is disrupted or interrupted, and I'm just speaking from my experience, but also I've noticed it on Medicaid Saves Lives, and one of the passes has a portal. I kind of expected it would go on there, but I'm not seeing like a live. Is there anything that says that their notices will go on there? Because I'm hearing more so from my provider, and I'm seeing that other members are about what's happening with services rather than kind of on the portal. And I don't know what the guidelines are with that.
So we have two different systems related to Medicaid. We have the eligibility system, which is ARIES, which is where these notices that we're talking about today came from. And we also have the MMIS system that is how the claims are processed, and service information comes from MMIS. So right now, they are not combined, and they do not all go to one place.
There is an application where you can get information on your benefits, what benefits you've used. I can't remember the name of it, but I'll get the information for you. I don't know that it contains your denials, but those should be going to the member. You're not getting your traditional Medicaid denials.
I'm getting them, but more, I'm not hearing from my pass about when the services are cut off, and then I'm hearing from my provider, and I'm trying to figure out, by then it's kind of it's not in a real, like a live, I guess I expected with the portal that they would go on there, but they haven't even gone on there. Like I'm getting like actual statements, but it's a week after or 2 weeks after.
I don't know what the passes are doing necessarily.
And I didn't know if there was some integration.
Yeah, no, there's no integration between like a pass saying you're not going to get the service anymore and like Medicaid, traditional Medicaid saying, because what we're reviewing is only fee for service claims. We don't review the pass claims, and they don't send us that information, just encounters.
And
so,
just as it's not y'all's system that I'm getting those for my one child, but the other child is like, I don't know. And then the provider's like, this is cut off, and you need to go. And I'm like, okay.
Just send us some information on that in an email, and we'll
I
follow
will.
up.
Yes, ma'am.
Okay.
All right, Shannon.
Now, I know this is specific for different programs, but I get frustrated because a lot of clients who are on waiver services who may be working get denied, and then the verbiage on the notice is you were denied because you're over in the income limit. So you could set up a Miller Trust, but there's another program out there that a beneficiary could apply for called the Working Disabled Medicaid Program. So I like it, that should be in that statement, because they could apply for that one. Yeah, that was all the feedback I had.
And thank you. I'm making that note.
So you're saying it'd be nice if a statement not only inform you you're denied, but give you some options of what you can do.
Yeah, you can apply for the Working Disabled Medicaid, or the Miller Trust.
Okay. Also, Rebecca is watching from home, and she said she appreciates Mary's attitude toward the feedback. So there you go.
It just will help us improve, and we have experience seeing the notices too. And Brandy and I were looking at a notice one day, and I was confused myself, and it came from my system, and I was like, I had to step back and then, okay, this is what this means. So it's welcome feedback, and I just wanted you to know we're working on it. I wish I had a specific day to give you. You'll start to see improvements here, but when we do make improvements, we want them to be noticeable. We want you to see that, yeah, this is different. Now, one thing about names on notices, you should already be seeing this. And in our long-term service and supports program, and Brandy, I think you probably work mainly with clients who get services through long-term service and supports. Those workers, we had always asked them to put names and phone numbers on those notices so the clients could get back to you. But in November, we implemented a change, and now any notice we send for requests for information, the worker who initiated that request, their name and number is going to be on that notice. And I can tell you, since we did that, we're about 4 months in, our phone calls into our call center are way down. Phone calls that I directly get are way down. And there's better communication, I believe, going on between our clients and the worker who's actually working that case at the time for them. So that is one improvement that has happened. And that came out of just a process change we decided to make and to improve customer service and communication and our own efficiency on our side. So that is something we've already done, and you will see more changes. It's just taking us a long time to get through that and figure out what we can do when and get that on the roadmap into our Aries system for the next, releases.
I believe Jacqueline had a question or comment.
I had a comment. I had a struggle the other day because I was on the internet using access.gov after our lovely tutorial the other day. And I applied for one program, and I was actually on the phone with the caseworker while I was submitting paperwork through my means of communication. And when I was doing that, I noticed that there wasn't a specific tab to submit documents for that program, so I had to submit the information they were requesting under my case for healthcare. And so now they got those two cases kind of mixed up.
All
That
right,
might be go ahead.
I was going to say, I think I'm going to need to get some specific information from you outside this meeting, because there are some things that you may need to provide that are not necessarily actually going into the eligibility system. It might be related to a medical review happening somewhere else. And so let me get with you and find out exactly what that is, because when I understand it better, it's something we can look at to see, is that something that we can add to our list of documents that you can upload, or specifically what it is.
The thing is, I've already uploaded everything for one case. My case doesn't even get a renewal packet until the fall.
Okay. So I'm going to get with you to get some specific information, and then I'll follow up with you outside the meeting. Okay?
So that is a good segue to our Access Arkansas live demo, since Jacqueline was mentioning Access Arkansas, and that's where that tab she was talking about exists. If you guys want to now ask Mary or suggest to Mary some of the things we learned from that Access Arkansas live demo. Rebecca texted me. She said she thought it was great. She learned a lot. Hopefully some of you who participated feel the same way. I know you had a light bulb. I almost saw the light bulb go off over your head. Yeah, when you said, there it is, that's where they are. So what did you guys think about the demo? And is there any suggestions or comments coming out of that live demo that you'd like to offer? It was the second time we'd done it. We did it with the previous council, and I think they learned a lot as well. Anything?
And I'll be glad to just give a brief overview
Sure.
of what all we did in that demo.
For those of you who weren't there or didn't participate.
So we walked through the process of how to create an account at Access Arkansas. We did a demo of just a test person applying for healthcare services and what the screens looked like. And at the end, when, we got the green check mark that said success and we got the confirmation number, called a T number, we demoed how to upload a document to the case. We demoed how to link the case. And we talked about the security requirements we have to meet. And having an account doesn't mean you can access anybody's case, right? So we have a process where you can link specifically to your own cases, or if you've been designated as an authorized representative for a client, how to link to the case that you've been designated an authorized representative for. We also showed where the notices are, how to see your notices at Access Arkansas. And we also then demoed, logging in as the authorized representative and how we could link the case to our client that we were the authorized representative for. We showed the help, how do what's available in the help. And we also got into a conversation about the Access Arkansas Client Toolkit. And I don't know that we have, we actively promote Access Arkansas, but our comms team is going to start actively promoting how to do things at Access Arkansas, because we have, I think I counted 14 different videos, and they're short videos. They're 1 or 2 minutes, most of them. I think the overview is probably the longest, but we, how to do things once you are at Access Arkansas, like how to create an account, how to link your case, how to upload a document, how to see your notices, how to set your alerts if you want to only receive e-notices instead of paper notices. So there's a lot of videos that we have, and one thing about a video is you can watch it over and over again as many times as you need to. We have those videos also are available in English and voiced over Spanish and Marshallese now. I think we're completed with. Not all of them. Not quite, but we're working on it. Yeah. So they will soon be available in all 3 languages. And if any of you watch the videos after the demo and have any feedback on the videos, we're happy for that. And particularly those of you who are using Access Arkansas, if there is something we didn't cover in the videos that you think would be helpful that we just don't have in those videos, then we can do a short instructional video on that particular thing. We've intentionally kind of broken up the process into those bite-sized videos because you might not need to see the whole thing, and you might not want to scroll till halfway through it to see the thing you want to know. But was happy to show that, and then we're going to start doing more promotion of that on our social media. Then we also did a demonstration of our community partner portal, and we talked about the difference between an authorized representative who can do anything a client can do. If you're an authorized representative, you can do anything a client can do, even if the client's not there, even if you don't have the client's login and password. But as a community partner, you can help the client. You can see the status of the client's case if the client has given you permission to see the status. And if you have 15 clients that you are their community partner and they've authorized you to see their information, you can see the status of all 15 clients at one time without logging into each individual client's case. But when it comes to being able to help the client do more, community partner is over-the-shoulder help with the client. So the client would have to log in, and you would help them go through the screens to apply, or help them go through the screens to upload a document, etc. So I think that is pretty much everything that we covered, but definitely happy to hear. Oh, I can tell you we are making an improvement there, because one of the things you can see with an Access Arkansas account is the status of your case, but it's pretty limited right now and pretty generic. And we got a grant from the USDA Food and Nutrition Service, and it was specific to the SNAP program. But this grant we are using to make that status more intuitive based on the individual case, okay? And late July is when phase 1 of that is gonna go into production and you'll see it. But it'll be better information, not just pending or not just approved, but more specific information. And in phase 1, you'll be able to see those statuses for applications and not just SNAP applications. The grant is going to cover the work to do it for SNAP, but we are using some of our systems budget to go ahead and do it for Medicaid and transitional employment assistance at the same time. And then we will a little bit later do the same type of status if you're due for renewal, or if your renewal is in progress, and or if there was a change in circumstances that was in progress. So we'll do it in phases, but you'll get better information on that, what's going on with your specific case at the same time. And we're incorporating into that different types of reminders and nudges, like if you have a notice pending and we're waiting on information for you. So those are improvements that are coming in phases starting in July, late July.
All right, let's thank, you have
I think
Shannon?
Shannon has a question.
My issue is, unless you guys have fixed it, you guys don't like list every possible Medicaid category that one can apply for. So I've often had people apply for the working disabled Medicaid program, but it's not actually listed there. It's kind of like in general. So I know it's like a system that's a catch-all for everything, but a lot of DHS workers don't even understand what that program is and where it is in the policy manual. And then at the end, I think there's a section for notes. It'll be helpful that you guys had a section for notes where a client could note what they're trying to apply for, or what their understanding of what that they're applying for, like a Medicare savings program. Unless that's changed, I think that would be really helpful to get feedback on a program that they're already on.
Well, and you are correct. We don't list every single category on the application or the Access Arkansas website, and mainly because we don't expect people to know, right? If you need help with health care, we don't expect you to have to know, I need to pick this category. We have built our system with all the health care rules in it. So if you qualify for workers with disabilities, that is going to be considered when we are determining eligibility. We do have the specialty categories, the LTSS categories in particular, like AR choices and the community employment supports waiver, nursing facility, TEFRA. We have the PACE is another. We have the special assisted living. I think maybe now I've got them all. We have those specifically listed because you can qualify for Medicaid, but we would need to know a little more information to know if we should be looking at those specialized services for you. So you can designate those, but in the system, workers with disabilities, if you are working with earned income and if you are disabled, or if you even tell us you're disabled, we're going to send you request the information we need to finish determining eligibility for you. And if you qualify in a different category, we also have a hierarchy so that we put you in the best category you can possibly qualify in. And we start, the best category, and then we go from there. We also have some dual eligibility allowed with Medicare savings and other programs if you need it, right? Because some of our programs are full range of Medicaid, and we're going to already do the buy-in and already do the things that Medicare savings would do. So I definitely hear that feedback, and I don't know that we want to list every possible category because most people aren't going to know which one to pick anyway. But maybe there is something we can do about the notes so that we can have, a specific, I'll take that back and see what else that we could do.
Like we talked about on the call, I think it would be good if we could get that toolkit over to all the folks that are on Understanding Medicaid Waiver Facebook page, because there's about 1,200 people there. And just, I don't think people really understand it, but if they could watch the video and understand it, I think you would see the utilization of it go up, because there's all kinds of questions always about what does Access Arkansas do, and I don't know who runs. I think Katie Sursa runs one of those pages, but we had talked about that on our actual training, that if we could get that out there and show the videos, and sometimes they do live chats for families and just to teach them that, because I think a lot of people would use it if they knew how to use it and what it was and was educated on it.
Well,
and again, the community resources, I thought that was just wonderful, and seems like you could link that with your Pathway to Prosperity program.
There may be possibilities there, definitely.
And so, Gavin, if we share things on our social media page, are they shareable to other social media pages? So once we start promoting the videos and such, hopefully they'll see it, or we could alert
pick
them and
'em
they
up,
could share it on their page. Yeah. Yes.
So quick question about when you were talking about linking or people not knowing what they qualify for. I think y'all do a great job on the homepage. At least I know several clients have gone through and used that. What are you eligible for? Does that not encompass almost all of the programs that you have, or is it just specific programs?
You know, I think it does. And she's talking about there is a portion of Access Arkansas where you can basically screen yourself for eligibility. You don't have to apply, but you can answer some questions and it'll tell you, you may qualify for this, this, or this.
And it does a great job because it links them right to the specific applications that they need for what they qualify for.
Yeah, I'm gonna make myself a note to review the screener and see if it does come up with specific categories, or if it just says, you know, you might qualify for health care. Would you like to apply?
Because we use that primarily just to determine whether or not, I mean, if a person just truly doesn't know whether they would qualify, it saves all the time of going through the application process only to find out that they're denied because they really don't qualify for anything.
And you can screen without creating an account. You know, you can completely anonymously do the screener tool. But if you want to apply, then you need to create an account to actually apply.
But that screening tool will ask questions about if you're disabled, if you're, okay, cool. All right, well, Mary and her team did a great job with the live demo. It took quite a bit of their time to put that together and to host it. So thank you, Mary, for doing that for our members.
Very welcome, and happy to take additional questions and feedback if you have it, even after the meeting.
Well, you have to go too,
I
don't
have to
you?
go,
Yes,
yes,
so,
but y'all can email me.
yeah. If you don't have Mary's email, contact me. I will get it for you. And she also, you can notice a lot of the folks have already left because they're off to their afternoon meetings, and Mary will join them now. But what we have left to talk about doesn't require them, because we're going to talk about the future of this council, the changes that are coming, and the MAC, which is about to be formed. Just for reference, I'm not in charge of the MAC. Someone else at DHS is heading that up. I'll be working with them, and we'll be coordinating efforts, but that'll be a different point person for those of you on this council who do end up serving on the MAC. I'm going to go through a little bit of background on this, and then we'll get into some things like, should we change our name? Who are the representatives from this council that are going to serve on the MAC? How will we determine that? But in 2022, CMS, which stands for the Centers for Medicare and Medicaid Services, they issued an executive order commonly known as the Access Rule. That's what we call it. We call it the Access Rule. It's really the Ensuring Access to Medicaid Services Rule. We just call it the Access Rule. And the Access Rule requires the creation of a Medicaid Advisory Committee, which they're in the process of doing right now. The application is live on our DHS webpage. Anyone that falls into these categories we're looking for membership can apply. And it requires the continuation of our council. A lot of states don't have what we have right here, the beneficiary council. They're having to add that piece. And so we already have that. We're going to keep doing what we're doing. In most states, it's called a Beneficiary Advisory Council. We call it the Medicaid Client Voice Council. We can change. We don't have to change. We can discuss the pros and cons of that in a minute. But back to the MAC, the Medicaid Advisory Committee. The goal of this committee will be to advise DHS on a wide range of topics, even wider than what we've been advising them on. So some of those things, and I didn't do a PowerPoint, but if you want me to share this, I'll just make a PDF document and email it to you guys. But so we'll be advising DHS on additions and changes to covered services, which we've made some suggestions on that here in the past on the council. Coordination of care, quality of services. If there's an issue with quality, we'll be able to bring that to DHS. Eligibility, enrollment, and renewal processes, much of which we've been discussing today. Enrollee and provider communications, again, we've been talking about notices and language today. Cultural competency, language access, Mary mentioned in Spanish, Marshallese in English, and health disparities in the state. Where are the health disparities? Where could more focus be paid? Access to services. Some access issues have come up today with transportation. Jacqueline mentioned transportation. Housing costs was mentioned. These can be access to services. And other issues that impact the provision or outcomes of health and medical services. So the Medicaid Advisory Committee are going to meet and come up with areas of improvement and submit concrete, in-writing suggestions or ideas to DHS. DHS, in turn, will have to take those back and come up with a written response. They'll have to say, here's what we're going to do, or here's why we can't do that, or here's why we like your idea, or here's why we don't like your idea. Whatever they're going to say, there'll have to be a response. It's not just going to be a suggestion that floats out there into the atmosphere and is never addressed. So the suggestions and ideas that come out of the Medicaid Advisory Committee will be there'll be a formal process of how to handle those. There will be a new meeting schedule. We'll be meeting quarterly starting this summer instead of 6 times a year. So we'll be meeting 4 times a year. The reason for that is the members on this council, 3 or 4, it depends on how big the Medicaid Advisory Committee is, but the members on this council will be at both meetings. And so if we were to meet 6 times a year and then they were to meet another 4 to 6 times a year, that's just a lot for the 3 or 4 members on this council. The councils will meet on the same day. So in the morning, the Beneficiary Advisory Council has to meet first because they may have some ideas to bring to the big meeting, or not the big meeting, the Medicaid Advisory Committee meeting. And so we'll meet first in the morning, then we'll break for lunch. So you'll still come in the morning, you'll still get lunch, and then the majority of the members of this council will go home. A few will stay for the next meeting, which will be the Medicaid Advisory Committee meeting. So who will be serving on that committee with you, for those of you who do? It'll either be 12 or 16 members. They haven't even decided yet. So the application I mentioned is live. They're getting applications coming in. They'll have to decide, do we want a 12-member council, in which case 3 of you will serve on the council because that council has to be 25% us. Or if it's a 16-member council, 4 of you will serve on that council. So they'll either have 9 or 12 people they'll be pulling from the community. Members will be pulled from Medicaid-involved organizations. Their representation will likely include clinical providers or administrators who are familiar with the health and social needs of Medicaid beneficiaries, such as those involved with pediatric care, behavioral health services, primary care, specialty care like aging and adult services, preventative care, reproductive health services. All of these fields that involve the Medicaid population could be members on this council. Also, members could come from state or local consumer advocacy groups. They could come from other community-based organizations that represent the interests of Medicaid beneficiaries or advocate for those Medicaid beneficiaries. And they could be participating managed care organizations, like the PASS's. Could be someone involved with a PASS or other managed care organizations. So they have a specific guide that they have to have members from certain pools, and it's up to them to create the council, whether it's 9 or 12 members, and have it represent what CMS requires. These are CMS requirements. These aren't coming out of thin air. They're requiring you to have certain representation on this council, including us. We're required to be on the council. So at least 2 of the meetings of the 4 must be open to the public and allow for public comment. All of our meetings have been technically open to the public. We broadcast them live. Anyone could show up and sit on the back row. We advertise them in advance on our website of where it'll be, what time it'll be. We haven't generally had, we did have a state representative or state senator come attend one of our meetings once, and we've had a couple members of the public come over the years, but generally we haven't had a lot of public participation. But that's not on us. We put it out there, and anyone can come. So we'll probably continue to do just public all the time. I don't know that we would go to 2 public and 2 non-public, but we'll decide that. And we must also publish on our website moving forward An annual report that summarizes the MAC and the MAC and the MCVC activities. We currently do newsletters that are put on the website, which kind of summarize our activities. This will be one annual report that'll have to be submitted to CMS. Our bylaws will have to be put online. I think they are. If they're not, I'll just put our bylaws online, and the MAC will have to create their own bylaws and put them online. The meeting schedules, the minutes, which I believe posting the actual video of the meeting is even better than the minutes. So we'll continue posting the video of our meeting online, but the meeting schedules will have to be laid out. And the formal responses that DHS makes to our recommendations via the Medicaid Advisory Committee, those will have to be posted. And the member recruitment and selection process, which I don't think is posted on our site, but it's no mystery. We have a process, we follow it, we'll just have to advertise it on the site for how we picked who's in the room here. So let's see if I covered all of this. Oh, and at least one of those quarterly meetings is supposed to be virtual. So really, we'll only meet in person 3 times a year instead of 4, and then we'll have one virtual meeting. So this creates greater access to those who come from far away. They won't have to travel for one of those meetings because it'll be entirely virtual. Right now, we have had a virtual meeting once a year. It's usually the July meeting, and you still get a stipend for attending because the meeting wasn't held in person. There was no opportunity to be here in person. So we've technically been doing one virtual meeting a year anyway. It's been the July meeting, but now it's formally required by CMS to have one meeting that's virtual. So we haven't decided the months. It could be January, and then 3 months later. So that still has to be decided. I'm guessing we have to meet by January 9th, according to CMS. Although I don't think that they would get upset if we did it after January 9th. But January, April, July, and October is most likely the 4 months we'll meet. Although that isn't in concrete yet. January, April, July, and October. So before we get into name change discussion and membership on the council, 2 other things. It seems logical that our chairperson and vice chairperson would fulfill 2 of these spots on the Medicaid Advisory Committee unless they don't want to, but I think they probably do. But we'll just have to pick 1 or 2 other members to join them. And those members don't have to be the only, they can rotate. So let's say Heather got picked or wanted to be on it, but then one time she can't make it. Someone could pinch hit for her and serve that day. It doesn't have to be the same members. It just has to be 3 or 4. So there's no requirement that the same 3 or 4 are there every time. It's just a requirement that 3 or 4 have to attend or be present. So any questions after all of that before we get into some discussion?
Jason, is there a plan? I know in other states that I worked in with managed care, the Medicaid Advisory Council, the MAC, was very influential and very active with the legislators. So they would provide their reports to like the public welfare and health committees. Have y'all talked about that yet? It just gave them insight into what we're seeing as members or caregivers, and we would take those suggestions and make sure it got to those particular 2 committees. So I didn't know if that had been discussed yet.
CMS doesn't require any communication like that. It's basically the communication that's required is between the MAC and DHS. And so, but the reports and their suggestions and all that has to be made public online. So any committee of lawmakers or any lawmaker can go see what's been going on. But there's no formal process required, and none, or that we've talked about as far as involving lawmakers in that.
Hey, I had a question about an email you sent us. You let us know that your role was going to be changing, but that you were still going to be taking charge of the council.
Yes.
Is there going to be any changes to that at all?
Well, right now we talked about this in the first part. I'm now Director of Constituent Services, which means I have new job duties, but I also have retained some of my old position duties, including this. They will be hiring another Chief Deputy of Community Engagement, and it hasn't been determined if that person, because they haven't even posted the job yet, but it hasn't been determined if they will take over this role in the council or if DHS will want me to keep doing it. I think they believe, I've got it down after 3 years. It's pretty smooth. the newsletters get done, the meetings get run, so they're probably just going to leave it status quo if I had to guess. Even if they hire a new person, they'll probably leave me in this role for at least a year while they learn all the other parts of the job. And it may be dependent on if this person really thinks, like if they really want to do it. They said, no, that should be part of my job, I want to do it. Obviously, if that were the case, I would allow them to do it. But no, there's no change planned right now.
And I had another question. Because I started volunteering with other local advocacy groups in Northwest Arkansas, and they were really interested. They actually told me they've been trying to collaborate with DHS for a long time.
Yeah.
And I was wondering if we can get that email sent to us where you will invite the public so that they can know more information as to what it's about, and also that link that you send me through email to apply for the MCVC, is that the same link to
No,
apply?
it's different. So it is on the website, and I can
Okay.
get you to the new link. It just
Okay.
went live last week. There's a
Okay.
different, so kind of like the link on the website to apply to be a member of this council, there's a separate page on the website to apply for the Medicaid Advisory Committee. It's very similar, and it's a similar application, but it's a different link. So I can send, if any of you have people in that, all those categories I mentioned, like Angelica's mentioning, she has some people in a nonprofit or a community advocacy that they want to apply, I can send you that link, or you can just go find it today online.
Yes, please.
Sure.
Thank you.
All right, any other questions? Yes.
What's the term limit on the new?
Still 2 years. Well, actually, I don't know for the Medicaid Advisory Committee. They're making their own stuff. It's still 2 years on our committee. And CMS says now you can serve non-consecutive terms. So let's say you served a couple years here and took a year off, you could reapply for membership on this committee moving forward. That's something else that's new.
Does the person from this committee that joins the other committee need to be active status?
Yes, the person who is participating in the Medicaid, that's a good question. Like, let's say Heather is elected and she'll roll off, so at most she'll attend 2 Medicaid Advisory Committee meetings before she would be replaced in the first quarter next year by someone else on this committee because she'll have rolled off this committee. But there's no requirement that we hire only, or that we hire, there's no requirement that we put only people who have more than you have left on the committee to serve on the MAC. You could do 2 meetings and then just roll off, and you would be replaced by someone else on the committee. Same thing with Brandy, which it would be good if we consider that. And so, you know, Jennifer, if she's on now, next year she'll have sat in on a couple of these meetings and she'll kind of know how it goes, and she'll be assuming the chairperson role. That's why I thought it would be good to have the 2 of you on, and then we can decide if we want to do a rotating basis or if we want to elect. There's pros and cons of both. It'd be nice to have the same 4 because, you know, they'll have an understanding of the other people in the room. They won't be playing catch up. But then again, it'd be nice to give all of you the experience of sitting in and being a part of that. So I really don't have a preference. It's totally up to you guys how you want to do that. And then the name change. So we have to decide 2 things here. We have to decide who are going to be the 4 or 3. We're gonna do 4, but we may only need 3. If it's a 9-person, if it's a 12-person council, we only need 3. If they go to 16 like we are, they're going to need 4. So we can decide today. We don't have to do it today because we're not going to meet till July, but at least we can start thinking about it. And then the name change, I told you last time, a lot of DHS and other organizations like this are moving away from client, the word client, and instead like to use beneficiary. I like Medicaid Client Voice Council, but I don't mind Beneficiary Advisory Committee or Council. It's actually Council, Beneficiary Advisory Council. Or you could come up with something totally different. There's no rule as to what we call ourselves. It's not mandated. We just have to fulfill the obligations under the executive order. So, all right, yes, okay.
So I've been thinking about this for a long time, but my feelings is that it should have the advocate word in there. So I came up with client advocates for Medicaid services, which would be CAMS, C-A-M-S. I don't know if anybody thinks that's good or.
All right, so there's one suggestion. You can write that down on your sheet if you want to have trouble remembering it. Clients advocates for Medicaid services, all right?
Is there any like pros and cons to changing the name from MCVC to BAC?
The only pro I can think of is we would kind of conform to the rest of the country. They're establishing Medicaid advisory committees and beneficiary advisory councils, so we would have the same lingo, but it's not necessary. And a con would be if you like our logo and you like our name and you're used to it and you don't like change, you'd want to stay with what we have. You know, if anyone else has a pro or con you'd like to throw in, we can debate it. Anybody? Pro or con or another suggested name?
I think it's great the way it is. You already have the president.
Yeah, it's just, it's more work for us, but, you know, but if you like.
And we're not all I mean, like, I'm not a beneficiary, but I advocate for people who are beneficiaries, so you know.
And then, I guess if you're, to your name, advocate, people advocate for themselves, you know, or they advocate, or other people advocate for them, so that could work either way. Nope. Okay. Any other name suggestions or ideas or thoughts on a name change? And again, we don't have to decide today. I just thought we should at least start kicking this around and thinking about it.
I'm still thinking, playing with stuff in my head. Those of you that know me know how I am.
Are you saying you need more time? Is this a filibuster?
But for right now, I think it's good the way it is.
All right, Jacqueline, for now, she reserves the right to change her mind, but for now, she likes it how it is.
Like you said, you've had it for years. So
Yeah, we have.
people are going to think it's something new
That's true.
when it's not.
Yeah, I think Gavin, when he brought this up, he just said, this, if we're ever going to change, for whatever reason, now would be the time since we're adding this other council, and it would be just a natural time. That doesn't mean we have to change. He just said, if it was something that we wanted to do, now would be the best time to do it. So, but like I said, it's your council. I'll do whatever you all wish. And we don't have some members here. They may have an opinion too. Rebecca went to a doctor's appointment. Catherine had a family emergency. So, you know, and the others, I don't know what their, why they weren't here. Oh, CAMS? CAMS, M. Medicaid services, clients advocates for Medicaid services. Yeah, you like that one? I could always do like a emailed like poll, like, or a, you know, and put some things out there and we could decide that way. What about membership? Is there anyone who feels strongly that they want to be a part of this Medicaid Advisory Committee and want to be that third or fourth member? Okay, let's just share your reasoning, and I'll.
I don't have a reason, but I'm just interested in learning more and being a part of it. I'm just like learning more, and
okay.
Also with like my current job, I do a lot of give a lot of feedback with how we can update software, change software, how it works, how to make it work better, how can we could change it. If we change it this way, what would be the pros, what would be the cons? So I feel like I could bring those expertise here to the back.
Here's two things that this group is going to require. One, you're going to be a part of a larger council, so we may have 8 ideas coming out of here. You're going to have to pick maybe 2 or 3 because all these different groups are going to have ideas that they're going to want to present to DHS. And 2, you're going to have someone who's a good communicator who isn't afraid to stand up and say, this is what we want to propose and here's why. Because you may get pushback from some of these. If you are proposing a rate increase or something, there may be people in the room that wouldn't be good for them and they may push back against it. I don't know if rate increase was a good example, but you know, an expansion in coverage or something, you know, who knows. And so you're going to have to be a good vocal advocate and concise and a good, what would be the word, editor maybe, trying to edit down the things that this council really wants to, you know, to advocate for. And so let's see, Amy, you had your hand up. You want to be on the council?
I want to be on the council because I came from a leadership position in the past, as now pretty much working full time as a special needs mom, just trying to advocate for my children. So I'm seeing it from both sides of the house, and I know there's a lot of folks on there that are providers, folks that I've interfaced with in a professional community, but my perspective is totally different now as a special needs mom with some of the barriers that I have faced. So.
I have firsthand experience like working with the insurances from when I was in the starting up the Obamacare, and also because I have a lot of subject matter experience personally with navigating the system with my daughter's insurance and myself. So I feel like we do need to have subject matter experts that kind of know the ins and outs and how to navigate, because I feel like that would be something like someone really useful.
All right, so we have quite a bit of interest. There may be others who are interested and just didn't raise their hand. Maybe what we could do is a hybrid. Maybe we could always have the chairperson and the vice chair attend, and then we would always rotate the third and or fourth member. And so we would have some consistency, but we would also have some variety and some people who could experience it, where if we pick 3 or 4, all the time members, that wouldn't be possible. So let's just for today say we'll have the chairperson and the vice chair attend the MAC meetings, and we will rotate the third and or fourth position amongst you, and we'll decide, like at the meeting before, who's going to be the ones to attend. Well, and if you don't want to do it, obviously at the meeting before, just say, I'm out of town, it's spring break, I couldn't do it even if I wanted to, because schedules change, and maybe if we get an idea of what's going to be on the agenda, although I don't know if we'd have it 3 months ahead, probably wouldn't, because we won't. Yeah, if they're going to be in this, so you're going to have basically the lunch hour to this committee is going to have the lunch hour to figure out, all right, here's what the council decided, here's what we're going to present, here's what we're going to ask DHS, here's the specific suggestion or program. So it will be a quick turnaround. No, yeah, it's another good point. We will not start at 11. We'll probably start like at 9 in the morning and meet until 11:30, and then break for lunch. And then the MAC will probably start at 1:30 and meet until 4.
So
yeah.
Somebody may not be able to spend the entire day.
Right. Yeah.
For that.
Mm-hmm. So that's another consideration. It will be a day-long commitment, but it'll only be twice, once a quarter or 4 times a year. So. Any other questions about changes? We'll keep thinking about the name change. We've kind of decided on the council member assignments or how that'll work. Any other questions or comments before we wrap up? Angelica.
I'm just curious about who's leading the MAC.
So the leader of the MAC's name is Crystal McMurtry. Crystal McMurtry. She works at DHS in the DDS, the Division of Disability Services group, and she was hired, and part of her job duties when hired was to lead the MAC and form and create the MAC. So she's asked me a lot of questions about how we do it. She wanted to see our bylaws. She wanted to see how we picked our members, but it's ultimately up to her to recruit and select who's going to serve on the MAC and make sure that it meets the CMS requirements.
Just another thing to consider is like Jennifer's got a 4-hour drive one way. Yeah. A 4-hour drive one way, and meeting at 9 o'clock in the morning and not getting done till 4 in the afternoon. Yeah. We may want to give her the option of rotating as well, because that's a lot.
Yeah, that is a lot. Yeah. And unfortunately, I don't think there's a change in the stipend if you go to 2 meetings, although I can ask. Maybe they could get 2 stipends instead of just the 1 for 2 meetings. I'll ask on that. Yeah, right. What'd you say?
I was saying at least accommodation, so she don't have to drive get up at.
If that's possible, but if you have kids, maybe you have to go home. I don't know. So. I'm sorry, who is this? Lori McDonald. Oh, so Lori is the chief of staff for DHS, so she's at the Capitol. She lives at the Capitol during the legislative session, but she's my boss now. She's my new boss. Gavin's not my boss anymore, so I can say whatever I want to him. Yeah. Yeah. Yeah, she's a great boss. Well, that's all I had. Unless anyone had any closing comments or any other thoughts, we do. Oh, we're not going to vote today on the name change. I'm gonna come up with some way we can do that online and decide. We may have some suggestions from some of the people who aren't here. So, but let me do what? I need to get back to my email. Oh yeah. Is anyone having? If any of you are having issues with your Medicaid Client Voice Council emails, talk to the ladies on your way out. They can help at least put you in touch with the guys, and maybe some of these guys in the back who are the technology experts, who can help you with that. But surely someone can help you get that resolved. I sent 2 to you, 1 to personal and 1 to. Have you had issues? No. Jennifer has. I should have sent this morning's link to your. Yeah. Okay. All right, well, if that's all, you guys get a little time back. We are adjourned for the March meeting of the Medicaid Client Voice Council. Thank you for your attendance.